Today's module is on Patellofemoral Pain Syndrome, sometimes abbreviated as PFPS. It's a very common diagnosis. Patients often present with anterior or pain in front of the knee. It often affects younger patients who do not have something structural or obvious such as knee arthritis. It's often associated with athletic activities or an increase in one's training regimen. A patient who might go from cycling 20 miles a day to 40 miles a day, and if that's not done with the right biomechanics, they'll develop PFPS. It's important to rule out competing diagnoses such as a meniscal tear, and in my practice I've often found that this can be a sort of a garbage can diagnosis where patients have been given this diagnosis without adequate physical examination and other diagnostic workup. When we get to the exam room, I'll talk about this in more detail. It's said that women have this problem more often than men, and it's thought because women have a higher Q angle. The Q angle is if you think about a woman having wider pelvis than men in general, it's the angle between the front of the pelvis and the patella or kneecap, and then to finish the angle to where the tibial tuberosity is. And women, because of wider hips, have a larger Q angle, and that's thought to give more stress on the patella. For PFPS, or Patellofemoral Pain Syndrome, you do a similar exam you would do for other knee disorders, partly because you're trying to tease out in your differential diagnosis whether other conditions might coexist or explain instead the patient's symptoms. So I showed in a separate module for meniscal tears that two classic tests for meniscal tears that we do are the Thessaly test. So I have the patient bending about 20 degrees on one leg. Typically I start the good leg, and I have them rotate. And if there's a meniscal injury, they typically have focal pain in the area of their typical pain. Patellofemoral pain syndrome, this is usually better tolerated. And then deep knee bend walking, this might hurt a patient with PFPS, but it tends to be much worse for someone with a meniscal tear. Okay, I'll move to examining Jennifer for the supine exam. We're again going to start with screening of the lumbar spine and the hip areas. I typically would be looking at a straight leg raise, but this also indicates hamstring tightness. I'm looking at the hip external rotators, hip external rotation range of motion. If this is tight, typically there's problems in the iliopsoas, TFL, and other structures of the hip that can affect knee biomechanics. I'm looking at internal rotation, and when the patient's on their stomach, I would also look at hip extension for subtle hip flexion contractures. I would typically also do tests I do for whether or not there's inflammation, warmth of the knee using the back of the hand, and I would do tests for knee effusion, the milk test, which I explained in other modules such as the meniscal injury module, and going into full knee flexion, which often when patients have a subtle effusion within the knee, they cannot tolerate full knee flexion. For PFPS, there's generally not as much focal tenderness along the femoral tibial joint line, but more tenderness in the patella. Sometimes activating or grinding on the patella will reproduce their pain. I find with PFPS that there's often a problem more proximally, and I'll explain that. But before I do, I want to point out that there's the so-called Q angle that has been described in the PT and orthopedic literature. And what they do, you palpate the anterior superior iliac spine, the front part of the pelvis here. You look at the midpoint of the patella, and then you look at the tibial tuberosity. And this angle, this Q angle, is generally larger in women because they have a wider pelvis. And they feel this partly correlates to PFPS. Whether or not that's useful in my practice is not clear, but it's certainly a risk factor according to the literature. What I tend to do in my practice is I tend to screen for more proximal weakness and tightness. So for example, Jennifer, if you can go on your side, and you'll almost always find this, you kind of pick it up at people's party, your friend's living room. This is like a very quick fix. You don't have to go to medical school for this. Hold the leg up here, be as strong as you can. And typically on the affected side, they're subtly weak with the hip abductors. They're often surprised by that. When you test them, you want the patient a little forward, and There's often a subtle weakness. The other side is not weak. I think part of what happens that explains PFPS is that TFL is sort of the poor man's gluteal muscle is what I call it. It's a muscle that originates anteriorly on the hip and it terminates at the iliotibial band. So when patients have subtle weakness of the glutes here behind, in the posterior part of the hip, they end up developing tracking problems within the knee because the TFL, when it's overactive, pulls the patella laterally. So you can do a lot of work for patients and friends by just having them strengthen the hip abductors. Try to have them work up to about 40 repetitions. I also recommend stretching of the hip flexors, stretching of the hip external rotators, the groin muscles, etc. And a lot of patients will get better with that, although again they might have to do a gradual return to play.